Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Dr. Martin Whyte, Associate Professor of Nutrition and Metabolism at the University of Surrey and a consultant in diabetes at King's College Hospital in London, here in Britain. Having received his medical degree from King's College, Martin completed a PhD at Guy's and St Thomas's Hospital, examining the metabolic effects of insulin in critical illness. He then completed his specialist training in diabetes and endocrinology and general medicine. Since 2012, Martin has combined his NHS consultant work with academia at the University of Surrey, being promoted to Associate Professor of Metabolic Medicine in 2021. Martin has published over 100 articles on the topics of diabetes, fatty liver disease, metabolic medicine, and the discipline and logic of medicine. Can't wait to learn about that. His clinical interests include understanding our metabolism, which makes his expert areas conditions such as type 2 diabetes, weight and or exercise-related amenorrhea, and fertility and menstrual disorders such as polycystic ovarian syndrome, to name just a few. In his spare time, assuming he has any, Martin is a keen runner and has completed 2 marathons. Kudos to him. I've never managed to do one, so I take my hat off. Martin is also the editor-in-chief of the esteemed EMJ Diabetes Editorial Board, so it's a real pleasure to welcome you to the podcast, Dr. Martin Whyte. Honor to have you.
Thank you very much indeed, Jonathan. Lovely to be here. Thank you.
So, firstly, can you share your journey in metabolic medicine, how everything began, what drew you to the field?
Yeah, did me. I think from medical school, I really enjoyed physiology and biochemistry and the integration of those in general medicine. And it always struck me that diabetes encapsulated really the multi-system nature of metabolic dysfunction and how intervening in a number of different sort of metabolic processes would help across the range of different complications in the body. So it was almost a natural approach for me. I love laboratory medicine, and it was always a bit of a toss-up between clinical diabetes or chemical pathology, but I really enjoy the patient contact, so that led me down into diabetes and metabolic medicine, and I've been extremely honored and lucky to be able to combine that clinical work with academia. So yeah, it's been good fun.
Certainly, during your professional lifetime, diabetes has become, well, I guess the science has advanced incredibly. I recently saw a program, I think it was from Cardiff, T1DRA, type 1 diabetes, they're looking for a gene that predisposes, and you can do a finger prick and they'll tell you whether or not you have the gene. So I did it. I took advantage of that. Actually, yeah, just inspired. Tell us a little bit about that program.
I think there's a huge amount of interest now in identifying type 1 diabetes prior to the clinical presentation of the condition. And I think we're still learning really as to how these tests should be used and in who should be tested. Excuse me. Obviously, historically, people have only been diagnosed with diabetes once the condition is presented, and we know, of course, that happens when you've really lost or exhausted about 90% of your beta cell mass. And so the rationale being that if you can identify it earlier, you may be able to do something about it and at least make the decline of beta cell function less rapid and potentially even, who knows, arrest it altogether. I think there's a few things to discuss around this, and one is, of course, we don't yet have a clear ability to arrest that beta cell decline, but the existing therapies that are being tested, a number of immunomodulatory agents, seem to delay the progression of that beta cell absorption by about 3 years. Simple things like exercise may help, and a lot of interest in verapamil, of course. And then, but going back into the testing, of course, that it leads to the dilemma, as with any genetic testing, is, okay, well, if you find a genetic risk, does that mean you're necessarily going to get the condition? And so are you simply leading to a degree of anxiety that needn't be there? Certainly the ESD conference that was just being a lot of interest around what are the implications if you identify one, uh, two different antibodies that are positive. Is that something that's clinically relevant? And so I think we're still feeling our way a bit in this.
Well, I guess it's like anything. Maybe if you can identify someone that is at risk, maybe they'll take lifestyle changes a little bit more seriously and get fit. So who knows? But as you say, watch this space. So you've had a couple of interesting recent publications that I'd like to touch on. Firstly, counting the lifetime cost of obesity analysis based on national England data, a pretty huge data set. What were the key findings?
Excuse me. Yeah, that was very interesting. There we were exploring uh, what the differences would be with over the course of a lifetime, uh, given the presence or absence of obesity. And I think the key take-home message was that, of course, as would be expected, that if you have obesity at a younger age, excuse me, you're going to be more likely to live for a number of years with obesity and thereby accumulate complications of obesity and the costs thereof. But equally, women, of course, at much higher economic burden because of the consequences of obesity transmit into their pregnancies and the cost of difficult pregnancies or complications to the children after birth.
Okay. So, I guess the value of a single system like the NHS is access to such data and the chances to do these kind of massive projects.
Yes, I mean, I think we are fortunate with the NHS in terms of the data we have. I must say, other countries, particularly Scandinavia, of course, have an advantage over us over and above what we're able to do. They have excellent patient level data, um, which is possible in the UK, but often requires a degree of linkage across different data sets and quite a cumbersome process to analyze that. Then these particular papers, that particular paper you quoted, we were looking more at uh, utilizing national and regional data rather than patient level data to make those estimations of cost.
Right. So there was another recent publication that caught my eye titled Exploration of the Social and Philosophical Underpinning of the Patient, what this means for people with long-term conditions, in which you start by asking whether healthcare professionals should use the term patient. So I'd like to ask you to explain the key themes of this publication. I learned to my detriment that you can't say epileptics. That's not politically acceptable. Um, and it's a person living with epilepsy. I get that. What I don't like, and I practiced half my career in the United States, is that they call them clients, and that made my teeth itch, frankly. So have at it.
Yes, I I really enjoyed writing that paper and working with colleagues on that, and um, it came about through the process you described. There's been quite a shift in, and I think a good shift in terms of the um, relationship between the doctor and I'll use the term patient for now, but and then patient. Um, but some may suggest that that's still a hierarchical notion, and the term patient would automatically therefore assume a sort of subservience, either rightly or wrongly. But what caught my eye, or what made me think, I- rather, was that now in this day and age where we have people living for a number of years with one or maybe more chronic conditions, whereby those chronic conditions may not actually be um, clinically presenting themselves. So diabetes is a very good one. Of course, you can end up with a number of complications from diabetes, but equally you may not. Is it right for that person to still be a patient, even though they're going about the daily business, they're feeling absolutely fine? And in what context should it be used? And So I think we would both agree that if you saw somebody at a bus stop who happened to have diabetes, you wouldn't say, "Oh, there's a patient." You'd say that's somebody at a bus stop who has diabetes. But perhaps in a hospital setting, and you're running a clinic, you'd say, how many patients do I have this morning, let's say, and that seemed a more viable alternative. And so it's to explore in what circumstances is the term patient appropriate and who should use the term. Because I think the other thing that caught my eye was historically doctors and nurses have generally used that term, but now we're seeing other people, allied health professionals. There's been a huge expansion in the number of allied health professionals. Let's say pharmacists. Historically, I think pharmacists have used the term clients, which kind of raised your hackles. But sometimes now they're being advised to use the term patients. And so when and where is it appropriate? I guess the final point that I thought was odd on a personal level was being in a diabetes conference, looking at data about a clinical trial where the column would have, let's say, healthy controls, another column saying person living with diabetes. And it just seems somewhat cumbersome and duly and duly it's sort of overly nuanced. And I felt that in a situation where you are giving in a clinical situation, in a clinical environment where the issue at hand is that condition, in this case diabetes, I think it's appropriate to use the term patient. But perhaps outside in other circumstances, it's not. So, sorry, there's a long-winded way of exploring that topic.
I think it's really important because, and maybe it's a function of my age, and someone said, "Aren't you frightened about expressing your thoughts about lest you be cancelled?" It's like I don't understand why we can't have intelligent conversation about things and maybe disagree without being disagreeable. And the assertion that there's something patriarchal or hierarchical about the relationship between a doctor and their patient, the person they're looking after, I'm frankly irritated by it because I've never thought of it as that. I've always thought that I'm the one that's privileged to be asked by someone at a wretched time of their life to help them.
Mm.
And I sometimes think that we're a little bit too quick to throw constructs, throw the baby out with the bathwater.
I
To
do
the
agree.
detriment of our profession and the people that we care for.
Yeah, sorry. I mean, absolutely. And because I think, yes, but by using the term patient, by having a patient, it means you now have a responsibility to that person. Whereas if you say a client, you could say, well, I want to go off and play golf. I'm going to cut this clinic short because it's just a client. It's not whereas a patient, of course, you have that responsibility. And to absolutely, I think there is certainly some benefit in using the term. The other thing that struck me on this was I love how language sort of evolves, and of course, there's no precedent for the times we live in currently, where people are living with 1, 2, 3, 4, 5 different conditions for an extended period of time. And so I think because of that, language hasn't evolved to create a term to describe such a person. We're still used to the model from the 19th century where you're either well or you're sort of at death's door. And so perhaps we need a new word to describe this new
That's a very good point. Well, we shall watch this space and see how things develop. So during my professional lifetime, our understanding of the relationship between metabolic disorders and other chronic conditions, has grown dramatically. Can you walk us through that metamorphosis?
uh,
Hmm.
between metabolic condition and chronic disease. Did you say?
Yeah, and other chronic conditions.
Yeah. Well, crikey. So I think, of course, what we've been seeing since around about the 1970s, of course, is a gradual but almost inexorable rise in overweight and obesity, such that Whereas I think immediately post-war, it would have been less than 5% had obesity. We now have approximately a third of the population, just under, with obesity, and probably 3/4 who have either obesity or overweight. So that's come on hugely. And of course, it's fascinating as to what's led to that. There's a whole range of, I think, socioeconomic factors underpinning it. We're seeing, for instance, in women, it's much more common to see obesity in people with a low economic standing, socioeconomic standing, than people higher economic standing. So there's certainly an economic issue. There's a cultural issue in terms of work we do, provision of food, and so on and so on. So that's been happening. There's that secular trend. Although I must say, it looks as though that's plateaued now. So it's not ever more increasing. It looks as though that level, certainly in the UK at least, is plateaued. And of course, that has led to a whole range of metabolic and non-metabolic sequelae. And so I think our knowledge has grown around the interplay between fat and insulin resistance, where fat is stored in the body, the importance of visceral fat versus subcutaneous fat in terms of leading to insulin resistance, and also what insulin resistance translates as. Well, of course, one thing is that means generally your sugars go high, you're more likely to have diabetes, but it's certainly also a pro-inflammatory state. Because of that, that's going to increase your risk of venous thromboses. And you have fat within the viscera, in the liver, and fatty liver disease is associated with a greater risk of fatty inflammation and fibrosis. You can end up with cirrhosis. And so what you're seeing is, as a consequence of obesity, you're seeing direct metabolic consequences in terms of hyperglycemia and insulin resistance. You're seeing pressure effects from actually just having a large amount of abdominal adiposity. So, for instance, varicose veins, pressure on your joints, osteoarthritis. Also, an inflammatory effect that can permeate the entire body system. So, for instance, asthma is more common amongst species. So I find it really fascinating how that adiposity leads to a whole range of consequences, not just in the metabolic sphere, but throughout the body. And indeed, now we're finally in a position with pharmacological development, having drugs that can lead to significant weight loss, and seeing reversal of all those different factors, and improvement in osteoarthritis, improvement in kidney function as a consequence of weight loss. So we're beginning to turn the corner, I think, in terms of the consequences of obesity.
Yeah. Well, I want to dig into a couple of the things that you said there, Martin. So, in the United Kingdom, folks are offered a free ultrasound to screen for abdominal aortic aneurysm when they hit a certain age. And it seems that everyone I speak to who's had one are told they have a fatty liver. I mean, literally, it's, oh God, another one? Oh, for goodness sake. Non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, NASH and NAFLD, are metabolic liver injuries, right? So how prevalent is this? Why? And what should we do about it? And I am going to come on to ask you about the GLP-1s,
Right.
because it's such like inevitably.
Yeah, thank you, Jonathan. Yeah, I mean, obviously, I should start by saying, of course, we should now be using the term MASLD rather than NAFL. So now it's metabolic associated liver disease. I think because
I can't keep up with it.
Yeah, that's right. I know these
things, one bloody acronym, and they change it.
These things constantly change. I think it's to highlight the fact that it's metabolic, and also I think there's some stigma attached to the word alcohol. You know, it was non-alcoholic. But you're absolutely right. Now it's MASLD and MASH. So
it sounds like a firm of lawyers or something.
Yeah, well, a cartoon series. Yeah.
Yes, it MASLD.
Right. Yeah. So absolutely. So it's associated with visceral adiposity, and visceral adiposity is of course associated with abdominal girth. So you if you're just depositing your fat around your abdomen, you're much higher risk. You'll also be depositing it within your liver, compared to the so-called pear-shaped body distribution. If you're depositing the fat on your hips, it's less proportionally as being in your abdomen and therefore in your liver. So it's certainly increased in line with the overall rise in BMI, but BMI is a blunt instrument in terms of determining that because it doesn't help distinguish body shape. So an abdominal circumference with a tape measure would be a much greater ability to pick this up. You're right. I mean, this is seen more and more in terms of how much is there out there. Well, estimates vary hugely, and depending on the population studied and how you're looking for it, by really quite extraordinary margins, from sort of 5% to sort of 70%. So it's very difficult to be precise as to how much of it there is out there. I think partly in view of that, and partly because, as you say, everyone seems to be told they have it. There's at the moment a reluctance to go for blunt screening, as you were discussing with abdominal aneurysms. So in the UK, we are in a position where if it's identified incidentally, as you say, with an ultrasound scan for X, Y, or Z, that should trigger further evaluation, but we're not blanket testing everybody for the presence of MASLD. I think in terms of how we approach the finding of a fatty liver on a scan, we don't yet have a nice, seamless nationwide service of filtering out those cases. There's been quite a push in the last few years to take this forward. Very broadly, what the key point in terms of identifying fatty liver disease is to identify those with fibrosis, because as you progress through stages of fibrosis, so you're going to increase your risk of cirrhosis, potentially hepatocellular carcinoma, or indeed liver failure. So that's the end point that you want to prevent. So you have a huge proportion of people with fat in the liver who will never go on to develop that. A proportion, and it's about 25% of people with fat in the liver, will go on to have MASH, which is inflammation within the liver, and it's only a sub-portion of that who go on to develop fibrosis. So identification of people at risk of fibrosis is the goal. In terms of how we go about doing that, a rough screening test is what we call the FIB4 test. It's a simple blood test looking at liver function, platelets, and age, and that helps screen as to the propensity to have liver fibrosis or the need for further tests. I think what we really need to do, Jonathan, is increase the provision of the next step, which is fiber scans or elastography, which is looking at the vibration, the degree of stiffness of the liver, with a greater degree of stiffness implying fibrosis or presence of fibrosis. Very few people should be having liver biopsies these days, and indeed the numbers are coming down. But once you've identified that high degree of liver stiffness, if there's any question that there may be a different etiology underpinning it over and above liver metabolic sort of fatty liver, well then a biopsy may be indicated. So we don't yet have a very good tools to identify inflammation in the liver, but we've got a reasonable tool at approximating the presence of liver fibrosis. And then, as you're saying, the next bit would be, well, what do you do about it?
Yeah. So, as a surgeon and someone who did a lot of laparoscopy, you would often see in the obese patient that their liver, normally you get hold of the gallbladder and you sort of push the fundus over the top of the liver to basically flip it up. But in the obese, the liver doesn't do that. And number one, it can be much bigger bulk, but secondly, it has that stiffness you referred to. But I don't think people are going to recommend that surgeons should be allowed to do the "can I pull the gallbladder over the top of the liver" test. I don't think that will catch on. What strategies can healthcare providers use to promote preventative care in metabolic health? And how do you encourage this in the next generation of doctors that you teach? Because we're good at disease care, we're not particularly good at preventing the consequences of a chronic condition like this.
Yeah, so right. I think historically, nutrition has been barely taught at medical school. I know almost like an hour in a 5-year course. Certainly, that was sort of my experience. So obviously, yeah, I think somehow building in nutritional education to clinicians, healthcare providers, is obviously a very important step here. Um, I think that likewise, the provision of um, dietary support in the NHS is inadequate, in my view. Again, is patchy. I think because of the sheer size of the problem with sort of 75% of the population either overweight or obese, it's extremely difficult to deliver um, comprehensive nutritional advice to such large numbers. So I think, therefore, we're reliant at the moment on internet resources, because that can bias against some individuals who may not have access or be able to use internet so well, as well as big group um, input. I still think that the advice around diets and type of diets is not good in the NHS. I think that there's been a lot of interest, for instance, in a very low calorie diet approach to reverse type 2 diabetes. And I think, that's good, but that's not for everybody. In fact, it was somewhat of a minority of people who took that up when offered it. Um, uh, and I think we shouldn't be putting all our eggs in one basket. What I would like to see is a much greater understanding amongst healthcare providers that patients should be offered a choice about what kind of diet they can manage in their life, because the only diet that works is one that the patient will stick to and can incorporate into their life. And so I'd like to see a much greater understanding of the different types of diets available, and then just giving an individual choice. But then not only that, but once that's done and a patient starts a diet, if it's not working, really after 4 weeks, you'll know if that's something they continue. If that's not working, try something else. Um, but of course, you need that ability to follow up on this. So I think all healthcare providers can use that teachable moment to a patient to discuss diet and the effect that diet may be having on that condition. Let's say earlier I mentioned asthma, not something you'd normally consider as a metabolic condition, but the awareness, let's say in this situation, of the respiratory physicians understanding that their metabolic dysfunction may be having a contributing effect, and using that teachable moment just to remind them about the importance of diet, uh, and to seek support and not to blame the patient and criticize them for being overweight, which just gets you nowhere. The study after study has shown that if you just say to somebody, you must lose weight, it's pointless.
Yeah, waste of time. Yeah, absolutely. It's about, you don't change your behaviors if you don't change your beliefs. And I have an expression. I've been working on a book for many years, which one day I'll hopefully finish, which examines all the different fad diets. And I maintain that probably the best thing to do is just buy all of them and carry them around with you. At least you'll get some exercise. I call my work the rhythm method of girth control, because people sort of diet, then eat, then they diet, then they eat, and you've got to change behaviors beliefs before you change behaviors. What's at or just over the horizon to aid in the early diagnosis of metabolic disease, and how do you see metabolic research influencing treatment options over the next 5 to 10 years? We mentioned I think it's TIDRA program, this blood test that I went for. So yeah, what's at or just over the horizon?
I mean, I think a great, um, uh, I think what we're seeing in the current age is direct to consumer marketing of a number of different tests. I think there's going to be an awful lot more home testing um, uh, in a variety of spheres, but not least amongst metabolic conditions. And so I'm already beginning to see a number of people self-diagnosing through that. Likewise, the ability to buy or obtain continuous glucose sensors. So a number of people have either bought their own and actually diagnosed their own diabetes from that, or used a friend's temporarily and did so. So I think as doctors generally, amongst a number of different disease areas, we're going to be seeing people who are more empowered to check their own health with wearables and different home testing, and coming to us to explain or understand what the meaning is of that. Um, uh, I think so. I think tech's a big thing. What was the rest of the question? I forgot now. Apologies.
So it was, how do you see metabolic research influencing
Oh,
treatment
big one. Yeah,
options? Okay,
yeah.
no
So,
worries.
um, right. So I think, of course, what we've seen over the last, how long would it have been now? Well, since the turn of the century, really. Um, a lot of research looking at the understanding of the incretin system, and um, the range of different incretins that are produced in the gut and the effects throughout the body and the potential synergistic effects of those. So I think that research has probably been the biggest um, change. It had the greatest impact, certainly in the last 15 years. There's no doubt we're going to be seeing more dual or triple incretin agonists, so-called metabolic bariatric surgery. Um, I'm already seeing data that's showing weight loss approximating that achieved with bariatric surgery. I think much greater understanding of the myriad pathways within the liver that leads to MASH and fibrosis that we discussed earlier, they're now being understood and dissected, and so therapies are being developed to intervene at a number of different points in these pathways to prevent or even reverse liver damage associated with metabolic dysfunction. So those are some big areas I think that we're going to see change in.
Okay. So we mentioned a little earlier the GLP-1 drugs. I think I know the answer to this, but I want your perspective. What impact are they going to have on disease burden? I was in Los Angeles not too long ago and was told by my colleague there that everyone is taking GLP-1
All right.
drugs,
Right.
even if they don't need them.
And if you don't need them yet. I mean, the effect is really, really, really dramatic. And of course, the newer agents are even better than the old ones. So I think the outcomes are, if anything, only going to get better. It's difficult, isn't it, they're almost a victim of their own success, or well, in a way they are, because of course stocks are low in the NHS because of the sheer popularity of the drugs. So who benefits most? But the issue is, of course, that there's very good data, for instance, from the SELECT study, which showed even in people without diabetes, clear reduction in cardiovascular events amongst those individuals. Huge amount of data in people with diabetes, of course, in terms of cardiovascular reduction. We're now seeing data. So, for instance, the FLOW study reported at the ESD meeting in September, showing a 24% reduction in major kidney events with semaglutide, one of the GLP-1 drugs. There's ongoing study, for instance, the STRIDE study looking at semaglutide in terms of reducing peripheral arterial disease. And then we're seeing other benefits with reduction in hospitalization, people using GLP-1. It goes on and on and on. So the difficulty is going to be, how do you identify those most at need? Because so many people could potentially get benefit from them. And how can the NHS pay for this? So I think those are going to be the huge challenges ahead. And allied to that, of course, is how do you transition people off them? So once you got the weight loss, we know that if you stop the drug, within 12 months, most people have regained the weight that they started off at. So we need much greater attention to the dietary change and exercise to help people transition off these drugs. Otherwise, I think, yes, we'll bankrupt the NHS. But it's very hard to say to somebody not to have it from a cost perspective when we know the benefits are so profound when you take them.
Yeah, absolutely. And of course, there was a report in the media of someone who succumbed to pancreatitis, which is one of the known risks. It was interesting in the narrative. Someone commented that this person was, quote, perfectly healthy, although from the photographs looked to be seriously overweight. And I think there's a misunderstanding by the lay public as to the long-term consequences of being obese. And we've just got to do a better job educating people, I really think.
You're right. I mean, I did see that news report as well, and obviously it's awful.
Yeah,
It
tragic.
it's difficult because, yes, we know that being obese, having diabetes, increases your risk anyway of getting pancreatitis.
Mhm.
And so, not wanting to comment on an individual case, but it's often difficult to determine whether it was the drug or the underlying
Right.
condition. Yeah.
Exactly.
Mm.
Yeah, exactly. Yeah. But we need the media to do a better job as well, I think.
Yeah.
Changing subjects a wee bit, spotlighting your work on fertility and menstrual disorders as we look back on polycystic ovarian syndrome awareness month in October. What can women do to manage the condition, and have there been any recent breakthroughs in this area? I know it's something there's increasing awareness about within women's magazines and such like. So, yeah, what
Yeah.
latest and greatest?
Right. So, yes, polycystic ovarian syndrome can absolutely be thought of as a metabolic condition. Insulin resistance is a driver for it. Of course, there are a subgroup of women who develop polycystic ovarian syndrome without any obvious overweight or insulin resistance, but it is a minority. And so I think it's yet another major complication from the secular trends in obesity that we've been describing over the last 40 years or so. Um, and, uh, and it can lead to quite significant problems. It can lead to factors relating to hyperandrogenism, of course, which is visually upsetting to a number of individuals. But absolutely importantly, it can lead to menstrual dysfunction, and so infertility issues. So reducing that insulin resistance will significantly help improve the ovarian function. And so that, again, that relates to any strategies that can work to help lose weight through diet and exercise. And again, data with regards to GLP-1 analogs. And what we were looking at was regards to bariatric surgery can significantly improve menstrual function and features of hyperandrogenism after bariatric surgery. So that's obviously an extreme measure to improve outcomes. I do think in many ways the academic interest in polycystic ovarian syndrome hasn't yet translated into specific drug development for these individuals. But I think that's something that's really going to come along in the next few years. But I think at this point in time, it's bringing home that public health message regarding the effect on polycystic ovarian syndrome. And just one other thing is what our own research showed is that there are a number of women who are putting themselves forward for bariatric surgery specifically in order to improve their fertility. And so, just as an aside, I think what we need to recognize as people working in that area is that although they're often told not to become pregnant in the year after surgery because of the potential problems of an acute catabolic state on developing fetus, that advice is often not being heeded, and they're desperate to get pregnant. And so we need to be aware of this as healthcare professionals as to why people are putting themselves forward for bariatric surgery.
Yeah, yeah. I've certainly colleagues who do a lot of bariatric work have told me of this phenomenon. So unfortunately, we're nearing the end. Martin, I always like to ask a question. If you came across a magical genie who offered you 3 wishes in your area of healthcare, what might you wish for?
Oh, wow. Um, I would like a very simple test to be able to identify MASH, because I think that trying to filter down that group of MASLD, which is, as we've been describing, a vast number of people, into a group that we should follow more closely, I think that would be hugely appreciated. Sticking to the fatty liver area, I think we're crying out for drugs that will help reverse fibrosis. We've got resmetirom that's FDA approved now, but is yet to be European approved. So that may help with sort of moderate fibrosis. But I would say that right now, in a very practical sense, I would desperately trying to get more people having the ability to start increasing therapy when it's clinically indicated. And I think the sheer supply issue is having a huge amount of problems at the moment. So I think I would probably use one wish to solve that immediate supply issue, where we're seeing a number of people who have, let's say in my liver clinic, a number of people with quite advanced fatty liver and early signs of fibrosis. And we know that if they can lose weight, that will prevent the progression to fibrosis. And we can't access these drugs, which is hugely frustrating.
So I'm afraid that that's all we've got time for today. I'd like to thank Dr. Martin Whyte for being with us today, and frankly for everything he's doing to help people living with these wretched conditions. It was a real pleasure to chat with you, Martin.
Thank you very much, Jonathan. It's lovely to be here, and thanks for having me on the show.
Fantastic. So, folks, if you've enjoyed this episode, please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts so you never miss an episode. Like us, leave us a review. You know the drill. And please join us next week for another episode of the EMJ podcast with another wonderful guest. Until then, I'm Dr. Jonathan Sackier. Thank you for listening. Please, everyone, stay safe, stay well, stay curious. Bye for now.